Assalamu alaikum. Welcome all of you. Today we'll talk about transposition of great arts. As we said in the group, we will have 8 to 10 lectures for the next 4 months, inshallah. I think they are the most lectures we need, or we all need to know in this period. Transposition of great artists, because it is the most common cyanotic congenital heart disease in newborn, and tetralogy of Fallot, because it is the most common cyanotic congenital heart disease in all ages, and duct-dependent congenital heart disease, because they are life-saving, as we all know. Heart failure, pulmonary hypertension, and syncope, chest pain, palpitation. The three symptoms that we see hundreds of children daily, and maybe also some emergency cases like supraventricular tachycardia and ventricular tachycardia, and long QT syndrome, some about arrhythmia cases. So we'll start today with transposition of great arts. What we mean today by transposition of great arts is the DTGA, dextro transposition of great arts, and we'll say the difference now, because we always say transposition of great artists, and we all mean DTGA. Not a lot of us know that there is another type of transposition of great artists called LTGA or CCTGA, corrected TGA. So what we mean by our lecture today by transposition of great artists, DTGA, dextro TGA, which is transposition of the great artist, not the ventricles. The transposition here at the level of the great artist, not at the level of the ventricles. Objectives: pathophysiology, prevalence, clinical examination, ECG, chest X-ray, echo, natural history, and management. Why we choose TGA to talk about as the first lecture in our 8 lectures for these 4 months? Because first of all, because TGA is the most common cyanotic congenital heart disease in newborn period, in neonatal period, not in all ages. In all ages, the tetralogy of Fallot is the most common cyanotic congenital heart disease, and it is common MCQ question. If the MCQ question is what is the most common cyanotic congenital heart disease in neonatal period or newborn, it is TTGA. What's the most common cyanotic congenital heart disease in all ages? It is the tetralogy of Fallot, but it is not the only reason why we choose TGA. First of all, because it is common. It is the most common cyanotic congenital heart disease in newborn. The second reason, because it is emergency disease with life-saving maneuver, as we will say after that, and as we all know, by using Prostin and Rashkent, and what are the emergency maneuvers, whatever the emergency maneuvers, which we can use, medical maneuvers or intervention maneuver. So if we say what's the most common congenital heart disease in all congenital heart disease, it is bicuspid aortic valve. So all of us need to know bicuspid aortic valve? No, because it's not critical, it's not emergency. But TGA, it is common and it is critical. So it is very important topic. What is DTGA? The normal circulation here, as we all know, the desaturated blood return back to the heart through the superior vena cava and inferior vena cava, to the right atrium, then to the right ventricle, to the pulmonary artery, while oxygenation of the blood occurs in the lung and returned as red blood or oxygenated blood to the left atrium, then the left ventricle, and to the aorta to give oxygenated blood to whole body. Okay? This is the normal circulation for a normal person. This circulation is called, we call this circulation that it goes in series. In series, every part gives the other part, and it is like in circle. So it goes in series or in circle. So the desaturated blood returns to the right side and go to the lung, becomes saturated and return back to the left side and go to the aorta and then to the body and return back as desaturated blood to the right side. In TGA, there is abnormal circulation. What happens in TGA? In DTGA, what we call dextro TGA, the aorta comes anterior and to the right from the right ventricle, and the pulmonary comes posterior and to the left from the left ventricle. So this desaturated blood, deoxygenated blood, return back to the right atrium from superior vena cava and inferior vena cava to the right atrium to then to the right ventricle, it should go through the pulmonary artery to the lung. But in TTGA, it goes through the aorta, return it back through the aorta to the body. So the body have deoxygenated blood and return it back to the right side. It makes separate circulation at the right side. The blood return it back to the RV, and through the aorta go to the body and return back to the RV, and so on. In the left side, the oxygenated blood from the lung return to the left atrium, then the LV pulmonary artery, and goes to the lung, and returns to the left atrium, LV pulmonary artery, and goes to the lung. So we have two parallel circulations. They are not in series. There is a right desaturated circulation, right blue circulation, and left red circulation. Okay, and it is incompatible with life. Nobody can live with this type of circulation. So if this body want to live, so he should have a shunt or a connection or a communication that makes mixing of the red and the blue blood. Okay? This shunt could be at one of the three levels. It could be at the interatrial level as big as Z. It could be at the interventricular level as V is Z, and it could be at the BDA. Okay? Most of the cases of DTGA, they have no shunt. They have only shunt at BDA. They have no septal shunt, only BFO and small BDA. This is the most common type of DTGA, and we call it DTGA intact septum. DTGA intact septum, and it is the common type that we all know, and we give the patient Prostin, and Prostin is life-saving. Not all types of TGA, the patient should take Prostin, and Prostin is a life-saving medication. The type which patient take Prostin, and Prostin is a life-saving medication, is the most common type, which is DTGA intact septum. The patient here has intact interventricular septum and semi-intact interatrial septum, only small BFO and BDA. So he lives through the BDA, and he is a duct dependent, because if there is no BDA, he will die. Okay, and he becomes one of the types of the duct dependent circulation, which we'll talk in another lecture. Okay. What happens in this patient? Blue blood returned from superior and inferior vena cava to the right atrium, then to the right ventricle, then to the aorta, and deoxygenated blood go to the aorta. But there is mixing of the blood at the level of the PDA. Sorry. Some of the blue blood goes from the aorta to the pulmonary artery, then to the lung, and then return back to the left atrium. Someone can ask here a question. What's the benefit of PDA here? If we have blue blood comes from the aorta to the lung and becomes red and returns to the left side and goes to the pulmonary artery and to the lung and returns to the left side, what's the benefit of PDA? Why PDA may increase the saturation of this patient? Because if PDA is patent, more blood goes from the aorta to the pulmonary artery, then to the lung, to the left atrium, and the left atrial pressure will be relatively high. So more blood will go through the small BFO to the right atrium, and then to RV, and then to the aorta. So patients with PDA, even when we give him Prostin, saturation will not be 80 and 90. It will be 60, 70. But without Prostin, if PDA closed, it will be 20, 30, and he will die. Okay? But PDA alone, PDA is not the main source of the mixing. PDA, here, the blood will not go as red blood from the pulmonary artery to the aorta. So size of PDA will not differ a lot. Blood will not go from the pulmonary artery to the aorta, but blue blood will go from the aorta to the pulmonary artery to the lung, and the venous drainage to the left atrium will increase, and the left atrial pressure will increase, and more blood will go through PFO, more red blood will go through PFO to right atrium, then to the RV, then to the aorta. So more saturated blood will go to the aorta, which may increase the saturation little, maybe 10 or 20. So saturation will be 60, 70, but will not be 80, 90. Okay. So if we have a patient with big PDA and very small restrictive PFO, it will be critical. It will be with very low saturation, even if we give him Prostin, even if the PDA is big. Okay, is it clear? This is the first type of TTGA, which is TTGA intact septum, where the site uh, of the mixing is the BDA. There is another type of VSD of TTGA, which is TTGA with VSD. If the patient has here VSD in the interventricular septum, what will happen? Like in this type. So we talked about the first type, which is complete TGA with intact interventricular septum. Its incidence is about 50%. It is the most common type. The patient will come with severe hypoxia or severe metabolic acidosis. Um, he will come cyanotic with hypoxia and acidosis. And this patient will need rush kit. We'll talk about it after that. And it is the most common type, but it is the typical type of TTJ. When someone calls me from SCABO or from NICU, and he say, I have a patient who is cyanotic, and I think with cyanosis, and I think he is cardiac. Okay, so I'll ask him, this patient is stressed or not? If he said the patient is not stressed, he is only he has cyanosis with no stress, so this patient is TTJ until proved otherwise. The second differential diagnosis is pulmonary atresia, but the first the differential diagnosis is TTJ. So most of the patient, which is complete TTJ with intact interventricular septum, clinically, he will come with cyanosis but not stressed. So if patient born in SCABO day one, his saturation is 60, 70, okay, but not stressed, he is calm, he is TGA intact interventricular septum until proved otherwise, until he did echo and he is diagnosed as pulmonary atresia or another diagnosis. Okay. If he is distressed, he could be PHN, he could be duct-dependent systemic circulation like critical coarctation, critical aortic stenosis, or other maneuvers. The other type, second type of TTGA with VSD. Here, the size of the shunt is the VSD. And we mean here by VSD, moderate to big VSD, not very small VSD. So there is mixing at the VSD, okay? And more blood will go from the aorta to the pulmonary and from the pulmonary to the aorta. So since the systemic pressure is more than the aortic pressure, the pulmonary pressure. So the RV pressure here, which oppose the aorta, will be more than the pulmonary LV pressure, which is the pulmonary pressure. So blood will go from the right side to the left side to the pulmonary artery, causing pulmonary congestion. So this type of patient will come more distressed than cyanotic. He will be cyanotic because he has mixed blood, blue with red blood, but he will have also respiratory distress. Will have a patient with saturation about 80, 90, okay, and distressed. This patient could be complete TGA with VSD. And this patient, he doesn't need prostatin because this patient, he is not duct-dependent circulation. His circulation is dependent on the VSD, not on the BDA. Okay. Third type, which is not very common of communication, is the communication at the interatrial septum level. This patient, he has not only small DFO, he has big ASD, and it is the best type. So if we choose which type is the best for communication, ASD, VSD, or BDA, the best type is ASD, then VSD, then the worst type is BDA. Okay, so the patient with TGA who has big ASD, big interatrial communication, will be better than patient who has big VSD, will be better than patient who has big BDA. Okay? Some of patients who have VSD has also BS. This is the third type, which called DTGA with VSD and BS. This patient have one advantage and one disadvantage. One advantage, as we'll say after that, that this patient could survive for 1 year and do maneuvers after 1 year, which is called Rastelli operation. Okay? But the disadvantage that this patient is almost more critical because only the TDGA as a disease causes cyanosis, and this patient has decrease in the pulmonary flow. So it has more cyanosis. So this patient came with more hypoxia and more cyanosis. Okay, but he doesn't need critical maneuvers and emergency maneuver in most of the patients. But if the CBS is very severe, he could need maneuvers at the first months of life. Then we have three types of TTGA. The most common type and the typical type, which we all know, is the TGA end acceptance. This patient has transposition of great arteries, aorta from RV and pulmonary from LV. And the site of the mixing of blood is BDA. The other type is TTGA with VSD. This patient has big VSD and this is the site of mixing, so he is blood dependent circulation. He doesn't need prostatin. Okay, and this patient we could do his maneuver at 2 to 3 months. TTGA VSD BS. It is the most critical type, but his maneuver could be done after months or years. Let's talk in detail. Prevalence, complete transposition of great arteries occurs in about 5 to 7% of all congenital heart disease, and it's more common in males than female. A clinical examination, typical clinical examination is history of cyanosis since birth, and the patient is calm. It is the first type. If the patient has TGA with intact interventricular septum, he will have cyanosis with calm patient without respiratory stress. If he has VSD, he will come with cyanosis and dyspnea and respiratory distress. If he has TGA with VSD and BS, he will come with severe cyanosis and maybe distress. This patient will be born, as we know, with severe hypoxia or severe metabolic acidosis due to the saturation of blood and low PO2. And lots of these patients will have hypoglycemia and hypocalcemia. In electrophysiology, in ECG, he will have right ventricular hypertrophy. And as we said in ECG workshop, it is difficult to diagnose RV hypertrophy in ECG of newborn because newborn has normal RV hypertrophy, which is according to his fetal circulation due to RV dominance. The only sign could be upright T wave in V1 after 3 to 7 days. We said in all neonates, T wave should be inverted after the third day to maximum the first 7 days. It should be inverted, should not be upright. If it's still upright after the third or 7 days, it's signs of RV hypertrophy. Chest X-ray, we know the typical chest X-ray of TGA, which is egg on side. Why it is egg on side? Because he has narrow waist. Because in TGA we lost the X relationship of the crossing, the relationship of the pulmonary and aorta arteries, and they come lots of cases side by side. So we'll have, and with in addition to the RV hypertrophy, it's causing this shape of egg on side. We have RV hypertrophy and small waist or base of the chest X-ray. It makes the egg on side shape. In echocardiography, the ones who attend the echocardiography workshop with us will see pulmonary artery coming posterior and to the left from the left ventricle, and the aorta comes anterior and to the right from the right ventricle. And as we said in the workshop, we shouldn't see both the aorta and pulmonary as long axis in the same view or short axis in the same view. We shouldn't see in the same view the pulmonary and the aorta as long axis or elongated like that, or short axis as two circles, because they are crossing each other. So if I cut this as a long axis, I should cut the other as short axis and vice versa. So if we see both of them, like in the right, in the shape in the picture, which is the right side, if we see both of them in the same view as long axis, it is a sign of TGA, as it is a sign that they are coming side by side, not crossing each other. Also, on the left picture, we see LV and pulmonary artery, which is branched coming from the LV, so it is DTGA. And in this views, we see the aorta, the circle which is above, which means in echo it is anterior, and the pulmonary, the circle which is below, which means in echo it is posterior. In echocardiography, we should comment about the coronaries. It will differ with the surgeons, it will not differ with the pediatrician, but it will differ from the surgeons. So we'll say why when we talk about the arterial switch operation, because he he resects the coronary arteries and re-implants them again. So you should know where is the coronary arteries, and because there are different types of coronary arteries in TGA. The most common or usual type is the left coronary artery coming from the left and branched, and the right coronary artery coming from the right. The other type may be lead only coming from the left, but the right coronary artery at left circumflex coming from the right. This is the second most common type. It may be common single coronary artery coming from the right, or single coronary artery coming from the left. Natural history. When we are talking to the parents in the cardiology clinic, they always ask us about natural history. And they are so smart to know that the most important thing is natural history. In congenital heart disease, natural history is maybe sometimes the most important topic in each disease. When parents come to us and I told him patient has pulmonary stenosis and this means that the pulmonary valve is thickened, that it doesn't open, he said, I don't know, I don't want to know that. I want to know how will he be, how will is it emergency case, what's the prognosis, he will need intervention or not, if he needs intervention we should do it or not. This is what's called natural history. Natural history, what will happen to the patient after that if he is still without intervention, does he need intervention or not, when he needs intervention, when he does need intervention, the incidence of being bad, the incidence of being good, something like that. So natural history of TGA, if patient has TGA and the hypoxia not resolved, and the TGA, especially TGA interceptor, he has no intervention, 90% of this patient will die before 6 months of age. So how many patients you know that have TGA interceptor without arterial switch operation or any intervention, and he is still alive after 6 months? It's very rare. It occurs, but it's very rare. So 90% of the patient who has TGA interceptum and he doesn't do any maneuver will die before 6 months old. If the patient has TDGA with interventricular septum, he will, with interventricular septum, his ticket type is the most emergency type. He is the type of patient who needs medication like prostaglandin, and he will need intervention like Rushkint or balloon atrial septictomy. The patient who has another side of mixing rather than the BDA, like big ASD or big VSD, this patient will come with congestive heart failure in addition to cyanosis, and maybe his main complaint, congestive heart failure, not cyanosis. The patient which has obstructive disease, who has PS, the patient, who has VSD PS, he could survive for longer time, and he could do his operations after 1 year. The management. What's the difference between the three types of patient to know how we can manage each type? Okay, so we'll return back to the pathophysiology of each type, and we will say what's the difference between them, and so how we can manage them. The most common type, which is TGA intact interventricular septum, this patient is duct-dependent circulation patient. He is the duct is a life-saving structure because it is the only site of mixing. So we need to keep this duct patent, and this patient should have prostatin while As long as the patient is diagnosed, he should start prostin, and we should correct the metabolic acidosis and hypocalcemia or hypoglycemia if it is present. Okay? But as we said in the pathophysiology, the PDA will not improve saturation. PDA will keep the patient alive. This concept we should know it by heart. That PDA and the patient with DTGA interventricular septum will not make mixing of the blood. That red blood goes from the pulmonary artery, which is red, to the aorta, which is blue. No, only blue blood would go from the aorta to the pulmonary and then to the lung and to the left atrium and decrease left atrial pressure. And more blood will go through the small BFO to the left atrium. So more saturated blood will go to the right atrium, sorry, then to the right ventricle, then to the aorta. So it's not a definite treatment. It is an emergency treatment only for days, for little or few days, and we need another definite maneuver to keep this patient alive. It depends whether the patient is in a cardiac center or not. If the patient is in a cardiac center or near to a cardiac center, he can do arterial switch operation after he can do arterial switch operation. If he cannot do arterial switch operation early, he can do another palliative maneuver, which is called Rushkent. What is the concept of Rushkent? Rushkent, it is what's called atrial septicectomy. What's the idea of this maneuver? We said before that the best side of mixing for patient with DTGA, we need mixing of the blood from between the left side and right side. And the best side of mixing is interatrial level, then the interventricular septum level, and the worst is the PDA level. So what if we can make artificial interatrial level septal defect? So we hope that the patient with DTGA is born with big ASD. How can we do big ASD? We can go through the inferior vena cava to the right atrium with balloon. This balloon is called Rushkent balloon, according to the scientist or the doctor who make it. And we hold this balloon through the B4. The balloon goes from the IVC to through the B4 to left atrium. So then it is inflated. Then we pull it. When we pull it, it cuts the right atrium, the interatrial septum, so it becomes big ASD rather than B4. The first goes here. This echo view. This patient has small BF4. This right atrium, this left atrium, it has small BF4. We go through the balloon, and the balloon becomes here into the left atrium, and we pull the balloon, and it cuts the left atrium. So in the right picture, he has big ASD. Then this patient has interatrial communication, which is sufficient to make mixing blood. So no need here to for the PDA. We can stop prostate, and he can go for arterial switch operation. I want a question here. I don't know if you know it or not. The timing of arterial switch operation. When shall a patient with DTGA do arterial switch operation? What's the timing of arterial switch operation? If anyone know, and why? I want to know what's the timing of arterial switch operation. What's the best timing of arterial switch operation, and why? Anyone know? This patient, we do for him Rushkent, which is atrial septicemia, and the saturation will be 75, 80, maybe more, 85. So he's fine. How long we can keep him after this operation without doing arterial switch operation? Do we need to do arterial switch operation after Rushkent or not? Anyone know? What's the timing of arterial switch operation? If I have a patient in Saskabo, and this patient was diagnosed as DTGA at day 5, day 7, day 10, day 15, what's the timing he should do when he should do arterial switch operation? What's the best time to do arterial switch operation? Okay. Okay, I'll say. Arterial switch operation should be done before 6 weeks of age. Should be done before 6 to 8 weeks of age, maximum 8 weeks of age. So arterial switch operation, the timing of arterial switch operation should be done before 6 to 8 weeks of age. I'll say what is arterial switch operation first, then I'll tell you why it should be done before this age. What's arterial switch operation? Arterial switch operation is the physiological operation for for TTGA. This patient has pulmonary artery coming from the left side and aorta coming from the right side. They resect, they cut the aorta here above the level of the coronaries and cut the pulmonaries at the same level, and they get the pulmonary to the left, to the right, and the aorta to the left. So it becomes with normal circulation. So we resect the pulmonary artery from the left side and make it at the right side, and we cut the aorta from the right side and make it to the left side and become normal circulation as in the right foot. Okay. But the cut is done above the level of the aorta. They don't resect the arteries from their roots. They cut the tube, the arteries above the level of the coronaries. So they cut the aorta above the level of the coronary and the pulmonary above the level of above the same level, and they put each in the side of the other. Then the aorta will come from the left side as normal, and pulmonary will come from the right side as normal, and blue blood will come to the RV to the pulmonary, and red blood will come from the LV to the aorta. We'll return back to the question, why it should be done before 6 to 8 weeks. Is due to what's called contingent and decontingent LV. What is contingent and decontingent LV? We can read it in the echo reports. LV is still conditioned, LV is deconditioned. It is the idea, I also say it is the idea as we get a lion and put him with sheep. Okay, by time he will become sheep. Okay, so if the LV got make LV with powerful muscle that can resist systemic vascular resistance, and RV is less powerful muscle or ventricle which can resist pulmonary vascular resistance. Okay, when LV contract against in patients with TTGA, LV contract against pulmonary artery, which is pulmonary vascular resistance, which is small pressure, okay, and RV contracts against aorta, which is high pressure systemic vascular resistance, okay. But in the first 6 weeks or 4 to 6 weeks, the pulmonary vascular resistance is still high. The pulmonary vascular resistance is the pressure of the fetal circulation, which is high. And this theory, we need it a lot in the cardiology management and cardiology congenital heart disease. In the first 4 to 6 weeks, the pulmonary vascular resistance is still high, and then sudden drop occurs at around 4 to 6 to 8 weeks. Okay, because the pulmonary vascular resistance is still high, the LV contract against high resistance. So it keeps its musculature and it keeps its cavity. Its cavity is still patent, and its musculature is still powerful and strong. Okay, so we get the aorta and put it in front of it. It can contract against systemic vascular resistance because it is still powerful, it's still strong. Okay, if this patient becomes 2 months old or 3 months old or 4 months old or older, the LV will contract against small resistance or small pressure gradient. Okay, so the muscle of the LV will become weaker. The LV 4 months contract against resistance like 25, 10, 25 to 30, like that. So the muscle of the muscle of the LV become weaker, okay, and it cannot resist systemic vascular resistance after that. So then if we get the aorta and put it in front of the LV, it will fail. Okay, this is what we call decongestion LV. Decongestion LV, uh, by echo and maybe by cardiac MRI, we measure the cardiac mass and the size of the LV and see if this LV is still powerful and with thick myocardium and thick muscle and big cavity that can resist systemic vascular resistance, or it becomes weak and cannot resist systemic vascular resistance. So arterial switch operation should be done in the first 6 weeks while the LV is still conditioned or is still powerful and strong and can face the systemic vascular resistance. If this patient did Rushkin, the saturation become fine, and we left this patient uh, for months or even years, the LV will be decongestioned, and then we cannot do arterial switch operation. We'll do another operation, which I will say now, which is called atrial switch operation. Okay, or there is another complex maneuver, which is called uh, two-stage arterial switch operation. We do pulmonary artery bending first, so the LV will contract against what's like PS, which is high pressure. It will gain power and muscle mass again, like gym. We make LV, we train LV again. We make like training for the LV, which becomes weak by making BS in front of it, like we give here dumbbells. So it contract against PS, which is high pressure, and become musculature increase and become stronger again, so it can face the systemic vascular resistance, and we can do arterial switch pressure at that time. But generally, in simple way, we should know, especially doctors in SCABO or in ICU, that arterial switch operation should be done in the first 6 weeks, 4 to 6 weeks, maximum 8 weeks. But it's before 6 weeks, it is the best time. So if we have a patient with DTGA, he should be referred for arterial switch operation before he becomes 2 months of age. This is a few of arterial switch operation. They cut the pulmonary artery and put it instead of the aorta, and the aorta becomes at the site of the pulmonary artery. And this also a view of the arterial switch operation. This aorta, they resect the aorta and they resect the pulmonary artery. As we see in this picture, they don't resect it as the roots. They don't get the arteries from their roots. They get the arteries above the level of the coronaries, as in picture A. Okay, number A. They cut it above the level of the coronaries, and they replace each one of as the site of the other, and they reimplant the coronaries in the new aorta, and the new pulmonary becomes anterior and taking this shape. This shape in you see like a saddle of the horse, which is called by French le combe. So it is called le combe technique. Le combe technique means they get the pulmonary artery anterior to the aorta, and the branches of the pulmonary artery become saddling the aorta, making like saddle of the horse. It is called le combe technique. So for knowledge, we should know that arterial switch operation abbreviation is ASO. So we can see a patient came to us. He is known case of DTGA status post ASO. What's this ASO? This arterial switch operation. Okay, and Lecombe technique is the technique of surgery. This cardiac CT, a cardiac multi-slice CT with reconstruction. Reconstruction meaning it is like cutting the parts which is extracardiac and making the heart as 3D model. It's called reconstruction in CT techniques. Yeah. So, this aorta, the pulmonary artery coming from the right side, and the aorta coming from the left side, and always the aorta will have aortic root dilatation. We don't want the the lecture to be more complex, but always the aorta by time will have aortic root dilatation and aortic regurgitation. Okay? And the pulmonary artery branches will saddle the aorta like this, like saddle of the horse, which is what the Tom technique. The most common complication of arterial switch operation is supravalvular pulmonary stenosis at the site of the resection of the arteries and reconstruction and reimplantation. At the site of these sutures, some patients have obstruction, so supravalvular pulmonary stenosis in the new pulmonary or supravalvular aortic stenosis in the new aorta is the most common complication. Also, we have complication of stenosis of one of the branches. This by echo, this leucom view, aorta will be like a circle, and the two branches will be like 8 in Arabic. Okay, like saddle of the horse. It's called leucom technique. And sometimes one of these branches will be kinked or cyanotic. And this common complication, both like in this picture. It is a common complication in post-arterial switch operation. Okay. As we said before, the best operation is the physiological operation, which is arterial switch operation. Because in all medicine, as we go to the normal physiology, it is the better, like breast milk, it is the better milk. So any artificial milk which is close to breast milk, it is the best artificial milk. Also, in surgery, the surgical technique which goes to the normal physiology and close to the normal anatomy will be the best surgical technique. So arterial switch operation is the best operation for DTGA. But sometimes if the patient is mid and he came now and he has what we said before, decontingent LV. The LV becomes small and weak and now cannot face the systemic vascular system. The other operation which we can do is called atrial switch operation. The arterial switch operation, we called it arterial switch operation because we displace the two arteries. We get the pulmonary artery in the site of the aorta and the aorta in the site of the pulmonary artery. Okay? And this operation is called atrial switch operation because the site of displacement will be at the atrial level. We get the pulmonary veins, okay, and make like a baffle or tunnel of the pulmonary veins to the RV. So the blood, red blood, will come through the lung to the pulmonary vein, then to this tunnel to the RV, then to the aorta, right? The aorta is coming from the RV because we are in a patient with DTGA. And the blue blood from the superior and inferior vena cava will go through a tunnel or what we call a baffle to the LV. So the blue blood will go through this tunnel or baffle to the LV, then to the pulmonary. Now we return to the circulation. The circulation will be like that. Superior vena cava, blood, desaturated blood will come through superior and inferior vena cava, and then through this systemic tunnel, what we call systemic venous tunnel, to the LV, then to the pulmonary artery. So blue blood will go to the pulmonary artery and to the lung, will be oxygenated and returned back as saturated blood to the pulmonary veins and through the pulmonary venous tunnel to the RV and then to the aorta. So we'll have nearly normal circulation, okay? The blue blood will go to the lung, the pulmonary artery, and the red blood will go to the aorta. But we have here, because it is not physiological, it is not normal circulation, we have lots of complications. The first complication in these tunnels, sometimes these tunnels will have a leak, sometimes will have obstruction. These tunnels will go through the wall of the atrium, so this patient is susceptible to arrhythmias. Okay, still the RV is the systemic ventricle here. Systemic RV gives the aorta. So this patient by time will have RV failure because, as we said before, gut makes the RV wall as a pulmonary systemic vascular resistance wall. It can face pulmonary vascular resistance, but cannot face systemic vascular resistance. So this patient by time may have RV failure and signs of RV failure and severe systemic venous congestion. Okay. In the switch operations, there are two techniques, one called mustard and one called thinning. It depends on the way the tunnel or this buffle is done. Thinning is self, thinning self, or from septal wall of the patient itself, from the patient himself, from the wall of the atrium or septal wall of the atria. Mustard will be done by pericardial patch. Yeah, but mustard will be done. It is the same technique and the same idea. Only how will the surgeon do this buffers by a pericardial patch, or he will make a tunnel by the wall of the atrium itself. Okay? So the third type, if the patient have TGA, VSD, BS. So if the patient has TGA, VSD like that, it is like TGA. Only the difference between TDGA intact septum and TDGA VSD is the timing of the operation. TDGA intact septum, it should be done in the first 6 weeks. Okay. TDGA VSD, because VSD make a load on the LV, so LV will not be decongestioned early. We said if the LV face only the pulmonary artery, which pulmonary vascular resistance will decrease by 6 weeks to 8 weeks, so it will be decongestion. But here, in the patient who have TGA and has big VSD, the LV give blood to the pulmonary artery and gives blood through the VSD. So it faces two pressures, systemic pressure and pulmonary pressure. So in this patient, if he has big VSD, the LV will not be decongestioned early. So the difference is the timing of separation, but the technique of separation is the same. He will close the VSD like that in this picture, close the VSD and make arterial switch operation. So if the patient have TTGA intact septum, he will have arterial switch operation. If he has TTGA intact septum with VSD, he have arterial switch operation with VSD closure. The difference between the two types is only in the timing. TTGA with intact interventricular septum, it should be done in the first 6 weeks before LV will be decongestion. TTGA with VSD, it should be done before 5 to 6 months or 4 to 5 months in order not to become Eisenmenger and severe pulmonary hypertension. But it shouldn't be done in the first 6 weeks. TTG intact septum is duct dependent circulation, and it is urgent emergency disease that he should have prostatin and he should have maneuver even Rushkin atrial by CAS or arterial switch operation or both. Okay? A TGA-VSD could have anti-failure and the operation could be done at 2 months or 3 months or earlier. Could be done in the first month also. Okay. But what if the patient has TGA, VSD, and PS? What is the difference here? The difference here between TTGA VSD only and TTGA VSD BS, that if we close the VSD and make arterial switch operation, the patient who had BS will have AS, right? Do you receive it? If this patient, we deal with him as only TGA VSD. He has TGA VSD BS, and we close the VSD and we make arterial switch. So the aorta will come instead of the pulmonary, and pulmonary become the aorta. The neo aorta will become at the site of the pulmonary, and the pulmonary become at the site of the aorta. And as we said before, and as I told you that it is an important note that in arterial switch operation, the displacement of the two vessels is not at the root, but it is at a higher level. It is above the level of the coronaries. So the patient who has PS will become AS. Okay, BS is simple or benign disease. AS is more malignant disease. If you see that, if you told that one patient have mild BS or moderate BS, he will be calm, but he has moderate AS, it is more malignant. Okay, so if this patient who has only BS, I will make him have BS, aortic stenosis. Okay, so in the patient who has DTGA, VSD, BS, we cannot do only VSD closure and arterial switch operation. What's the operation? What should be done for this patient? It depends on his clinical status. If this PS is very severe and critical, and this patient has severe desaturation, so he should have emergency maneuvers. He will have Rushkin, like اللي هي atrial septotomy, like the patient with DTGA and septum, by cutting the BFO and dilatation of the BFO by balloon. تمام. And he may also have what's called empty shunt, this white Charimo, which is in the right picture. Empty shunt is a shunt between the aorta or a branch from the aorta to the pulmonary. So it bypasses the site of the stenosis and will make red blood go from the aorta to the pulmonary and increase saturation. Okay? But if the patient is stable and saturation is above 75, excessive saturation here is 75, saturation is above 75 and the patient is fine. What shall we do for this patient? This patient LV will not be decongestant because LV here it 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 faces VSD and it faces BS, it faces lots of pressures. Okay, so it will not be decongestant. So I'm not in hurry to do operation in order not to have decongestant LV. So this patient may be left until he become 1 year old or older and do another operation which is called Rastelli. And sometimes we call it ventricular switch, but it's called Rastelli. What's Rastelli? Rastelli is closing the VSD with a patch, with a big patch and a tunnel, which makes the aorta comes from the LV, like this black patch. We close the VSD with a patch, by a way or a tunnel or a big patch, which makes the aorta comes from the LV, and will make RV to pulmonary conduit or conductor from RV to pulmonary artery. Here, the blood will come from desaturated blood. The blue blood will come to the superior and inferior vena cava, to right atrium, then right ventricle, then through this contegra or conduit to the pulmonary artery, and return becomes saturated and return to the left atrium and left ventricle and go through this baffle or tunnel to the aorta. So blue blood will go from right atrium to right ventricle through this artificial conduit or contegra or connection to the pulmonary artery. Blue blood will go to the pulmonary artery and return it as red blood to LV and through this tunnel or a stelly tunnel to the aorta. So it is normal circulation. What's the problem here? It is better than atrial switch because the LV becomes the systemic ventricle and the RV becomes the pulmonary ventricle. Okay, the problem here is in this contegra. This contegra sometimes by time it will become stenosis, it become calcified. So this type of patient sometimes you will need to change this contegra to make dilatation for it, making stent in it. So the problem here mostly will be in this contegra. This big batch, this big VSD batch, sometimes make LVT obstruction, arrhythmias, or something like that. There is another maneuver which could be done in the first weeks of life, because as we said before, it is better to do arterial switch operation. So some surgeons prefer to return back to the arterial switch operation. So he say here the problem which make us cannot do arterial switch operation, that the BS, right? What if we get the two arteries from the root and they make the aorta, or takes the aorta by its root and put it to the left side, and to take the pulmonary artery with its root and put it in the right side. And if we have BS, we can change it with contegra. I think it is more complex, but the idea simply, he takes the aorta from the root, which is good aorta with good aortic valve, and put it in the LV, and get the pulmonary artery from its root and put it in the RV. If he did that alone, it is called double root switch. It is like arterial switch, but with the root, not from the tubes. Well, he takes the arteries which is with its roots. Okay, it is called double root switch. If he changes the pulmonary valve by this contegra, it is called Nikaido. Okay, this complex operation, and to take artery from its root, there is lots of complications. So not lots of surgeons can do it. It may be better than Rastelli, if someone can do it fine, يعني, with no complication. But Rastelli, if it's not physiological operation, but it is the more safer operation, so the most of surgeons do Rastelli, not Nikaido. As we just have a workshop about fetal echo. This is TGA in fetal echo, just for fun. This is the heart of the fetus, and this LV, pulmonary artery coming from the LV, and aorta coming from the RV. It's like TGA in pediatric echo. And thank you. Any question?
Hello, Ahmed. Good evening.
Assalamualaikum. How are you?
I'm fine. Sorry, I came late. I have a good talk. Thanks. But little detail because you are working in with the surgical team now. So it was nice. Very good.
Thank you, Dr. Baba. Yeah, if you want to know the most important notes in this lecture, the first note that if we have a patient day one in SCABO and he has desaturation about 50, 60, 70, and he's calm, he is TTGA until proof otherwise. So we can start prostin either before doing echo. We don't need to do echo for this patient. We can do echo, but if I have patient now in SCABO and his saturation is 50 or 60 and he's not respiratory, he is calm. So this patient is TTGA until proved otherwise. It could be pulmonary artery, but it's almost 80% is TTGA. So we can start prostin until we do echo for him. The second note in this lecture that TTGA is not one type. We have three types of TTGA. TTGA intact septum, which is the most common type and the typical type, which we all know, and TTGA VSD and TTGA VSDBS. So some patients with TTGA will come with saturation about 85 to 90 and with congestive heart failure. And he has TTGA, but he has big VSD, which makes mixing and makes saturation better, but he will have congestive heart failure symptoms, and this patient will not need prostin because it's not duct dependent. Not all cases of TTGA are duct dependent. Only TTGA intact septum is duct dependent, or TTGA and VSDBS with severe BS, critical BS, as they are duct dependent. The third note in this lecture that the timing for arterial switch operation for patient with TTGA intact interventricular septum should be done. Arterial switch operation should be done before 6 weeks. So if I have a patient if we have a patient 5 days, 10 days, or something like that, I should know in the SCABO or in the NICU that I only have about another 10 days or 12 days to do arterial switch operations. So I should hurry to escort the patient to a cardiac center where he can do arterial switch operation. I think these are the most important three notes in this lecture. Any question? Okay, thank you all, and inshallah see you in the other operation about the tragedy the other lecture, inshallah, about the tragedy fellow after 2 weeks. Thank you.